by the end of the healing process, you're going to end up with a very large alveolar bone defect in that area. And then when you try to replace those teeth with implants, you may end up in a situation like this, with very long teeth, with staining on the gum tissues, because when you try to do the bone grafting, it somehow was not very successful. Another way of trying to fix this problem would be with the production or the delivery of pink ceramics, but if the patient has a high smile line, this is not something that they will tend to accept, because the reality is that it does not look good. So in these situations, it's all about timing. So time might be an illusion, but by timing itself is an art. And this is fully applicable for the replacement of teeth after a tooth extraction. What we know is that we can try to either take one of two strategies. Strategy number one would be to try to take the tooth out and go back into the area as soon as possible within the first 8 weeks. Or alternatively, we will have to do some sort of ridge preservation, like what you can see that now in the screen. At the moment you take the tooth out, we can to potentially apply some bone substitutes into this socket. You can see that we have a missing buccal plate in the area. Apply both soft tissue substitutes and hard tissue substitutes. At the moment, we're placing some bovine bone mineral in there with a soft tissue graft which comes from the roof of the mouth, from the palate of the patient. It's already somehow sutured in place. Then we will cover the whole area with the soft tissue, suture everything down until it's nicely covered. And eventually, if we do this, we may be able to prevent the need for major grafting. You can see this is the same case now when we're placing the implant. We are drilling through that bone. We did not manage to preserve fully the bone. You can see that the drill is coming through on the apical aspect, but the amount of grafting that I will have to do in this area will not be too much. It will be just a small amount of grafting that I will be able to get away easily with. You can see how the drill is shining through in there. And the grafting in this area, again, very predictably, I will be able to manage the issues I have. I place my implant, some bone grafting, a membrane on top. Here we go. This is a very predictable treatment. So again, 3D printing in this area could be applied. We have some research, as you will see in 1 second, that shows that we could be printing some 3D scaffolds if we're trying to do a ridge preservation. Again, my experience is that for this type of defect, in general, they are fairly well contained, fairly easy to manage. Only in the cases where we have a very large defect, where we have lost all the buccal plate, where we have lost the apical aspect of the bone surrounding the tooth, those could potentially be good candidates, but again, the great majority would not be a good candidate. And that leads us to the scenario where we can actually use the 3D printing. And that would be if we did not manage to preserve the ridge, if we just take the tooth out and we leave it to heal over time, we will end up with a defect which is very large both in the horizontal and the vertical direction. Traditionally, what we will be doing is at the moment, we will be doing a block graft. You can see here that we would go to the chin, harvest a graft, transfer that into the area that we want to augment. So eventually we can place an implant in that area. The problem with this technique is that it's very technique sensitive. First of all, it's difficult to do. The outcomes are not as predictable as for the other models that we have discussed up to now. It's challenging. It takes a lot of time. So there is a lot of surgical trauma involved, both for the donor side and the recipient side. There is a lot of things going on, and there is a lot of room for improvement. So this seems to me like the perfect effect if we're trying to apply 3D printed technologies. You can imagine the amount of time that it takes to adjust the graft so it fits into the space. So if I was able to have something in advance which has been customized and 3D printed for my patient, then I would be a very, very happy surgeon. And potentially I have the ability to reduce the morbidity for the patient because I am avoiding having to go and harvest bone from another site in the mouth. And I will also be reducing significantly the amount of time that the surgery will take and the amount of trauma that I will be creating for the patient. So yeah, that was the introduction on what we think in terms of the models. I hope that I have helped you identifying that a patient would like to avoid this type of harvesting of bone from another part of the mouth. Also, there is a great number of complications in the last model. So if you try to augment the reach vertically and horizontally, or especially vertically, you will find out that there is a large number of complications reported in the literature, ranging from 30 to 70% of the cases, which varies depending on the technique that you're using. But in any case, it creates a significant deal of stress, both for the patient and the clinician. So what can we do different then? How can we apply technologies, new technologies, to try to manage these large vertical and horizontal defects? If we want to try to obtain regeneration, we will need three things. One obviously will be cells, another one will be bioactive factors, and finally the scaffolds. When it comes to cells, this could be combined with 3D printed scaffolds. So we will briefly discuss this now. We published a systematic review at the end of 2019, in which we look at all the evidence for stem cell therapy. This is another line of research that we're having at the Eastman. And what we know is that there is a high potential for stem cell therapy to be combined, especially with 3D printed scaffolds, to try to obtain better outcomes in this model. We are trying to do some research at the moment where we have like the 3D printed scaffold that Sarah will present later on. We are trying to study whether we could improve the angiogenesis of that scaffold by combining with stem cell therapy. We are doing that in a chick embryo model. So we have like the chick embryo, we can put the scaffold in there with and without the stem cells. And what we're seeing is that initial angiogenesis is significantly improved in the 3D printed scaffold by adding stem cell therapy. Another factors that we will need to take into account is the growth factors that we could add into the scaffold as well. Again, it's outside the remit of the presentation today, but there is some systematic reviews that you can look in the literature. And potentially the addition of these growth factors to the scaffold will improve the outcomes. But finally, it takes us to what we wanted to see. So how can we, from a surgical point of view, introduce the 3D printed technology to try to improve the outcome for vertical and horizontal bone augmentation? We are going to discuss two different things. On one side, what we are applying already in the clinics and which is available commercially in the UK through Geislich, which is the Rio system. It's a 3D printed titanium mesh, which is customized for the patient. And then at the end, I will pass the presentation to Sarah, who will be discussing another idea that we have, which is the application of a 3D printed hydroxyapatite block graft for this type of defect. So we discussed before, there's plenty of applications in the literature, but there is not much really being applied in the clinics yet. What you see on the left of the screen is a 3D printed stent that has been reported to be used for sinus lift augmentation. What we're using in the clinic is slightly different. So I will present this with a couple of cases that have been treated by students at the Eastman with Professor D'Aiuto. Basically, this is a case that needed a rich augmentation for dental implants on the upper left 4, upper left 5, upper left 6 position. This case was treated by Stella Bath, one of our students, again with the help of Francesco. You can see that there is a defect both vertically and horizontally. So what we did is we took a scan of the patient. We designed a 3D printed titanium mesh. A titanium mesh that was going to be 3D printed. That titanium mesh is trying to reconstruct both the width and the height of the defect up to the point where we would like to regenerate the area. You can see how it can be easily designed and extended up to the point that you want. And once it has been 3D printed, we can go ahead with the surgery. What you can see in the screen at the moment is the sinus lift itself. Once the sinus lift has been completed, we can then place the combination of BIOS and autogenous bone graft in the area, and on top of it, we can fit the titanium mesh. You can imagine how much time we have saved by having something which is individualized and customized for the patient in advance, rather than having to, now during the surgery, customize a titanium mesh or a membrane for the patient. So I would say that you cut the surgery by at least 15-20 minutes easy, and that may have a significant improvement on clinical outcomes. So the fit of these titanium meshes is actually quite good. It comes with some screws that you can fit on the apical aspect, to get sure that it doesn't move around once it has been secured. And then all you need to do is to cover the titanium mesh with a resorbable membrane, and finally close the tissues. This is how it would look about 8 to 9 months after the treatment has been provided. Obviously, it's a radiograph. It seems like it might be effective, but with the titanium mesh still in place, it's a little bit difficult to see. So then when we actually open up, we could see that there was a huge amount of bone volume, which was gained both, again, vertically and horizontally. We have gone from a ridge which was barely about 2 millimeters in width on the most coronal aspect to something where we have at least a good 25 millimeters of width. And the vertical gain was 100% of what we wanted to obtain. These titanium meshes are very clever. They are not only 3D printed, but they are also very easy to remove. When you come back for the second surgery, the design of the titanium mesh has been done in such a way that there is a few weakest links across the mesh itself, and when you try to pull it, it just breaks very easily. So in this particular case, what we can see is that 9 months after treatment, when we take a new CBCT, we have had a gain of vertical bone of about 15 millimeters, and if we were to look at the width, we gain up to 25 millimeters in the widest part and about 10 millimeters in the narrowest part. So a very, very successful outcome. This is again the pre-op or the intra-op before placing the titanium mesh. You can see the thin ridge, and then how it healed over time at 9 months when the re-entry surgery was done, how we had gained a significant amount of width and height. Now this case is absolutely ready to receive a dental implant on the upper left 4 and the upper left 6 position. We have gone from a situation where it would have been impossible to place any implants to a situation where it would be very predictable to place dental implants to replace the missing teeth. Let's move on to another case, and this case I have it here to highlight that there are still challenges with this technology, and even when it gets you to, from a clinical point of view, to be a lot faster and potentially create a lot less trauma, there are also complications when we are trying to use these 3D printed meshes. This is another case that was treated at the ISMAN with the help of Dr. Vipul Patel, one of our students that graduated this year, and again, Professor Dayuto. The patient wanted to receive dental implants on the upper right 2 and the upper left 2 position. There was a huge defect in terms of width. We only had about 3 millimeters of bone, so we were unable to place any implants in those positions. This is very typical in cases of hypodontia. You will see that you don't have ever enough bone to place an implant in there. In this case, we could have placed a block graft, but we wanted to try something which was, again, less invasive for the patient. So we went for the 3D titanium mesh once again. You can see the design of the 3D titanium meshes there for the upper right 2 and the upper left 2. And these are the intersurgical pictures, very similar to before. When they open up the surgical area, there was a large horizontal defect on both the upper right 2 and the upper left 2 area. We use a combination of bios and autogenous bone harvested from the same area that we're doing surgery, so we don't need to go anywhere else in the mouth. We put that within our titanium mesh, then we adapt our titanium mesh to the space, and we just have to secure that with some screws at the apical aspect, both buccally and palatally. You can see the screw here on the apical aspect of the titanium mesh with the screw hole that was already incorporated into the design. That's the healing, and this is the reason why I have this case in here. You can see that we have an exposure of the titanium mesh. We can see discoloration of the soft tissues despite of the best possible surgical technique. So these techniques still have complications because it's still not bone, isn't it? You're still introducing a titanium containing product that will have similar complications to the titanium meshes that we use for vertical ridge augmentation at the moment. You could expect still probably about a 20 to 30% of complication rate with these techniques. And although we have saved a lot of time and we might have reduced infections overall, we may have still a compromised outcome. So this is what makes us think, okay, so potentially instead of having to use all these titanium meshes that even when they may allow us to place the implants where we want to have them, what if we could try to produce a 3D printed graft which is synthetic and may mimic bone in a much better way? What you can see here in the screen is some of the work we're carrying at the Eastman at the moment. You can see the CBCT of a pig jaw, and you can see how Sarah is playing in a lot of detail now, how basically we have created a workflow to go from that scan that you can see on the top to the design of a 3D printed hydroxyapatite block graft, the 3D printing itself in this small video here, and finally how we are trying to apply it already in defects that we have this design in pig jaws. So I will pass the presentation to Sarah now because she will be taking over and discussing this in a lot more detail. Thank you everyone for listening.
Thank you, Dr. Federico.
I believe you can see my screen. So, okay. So thank you, Federico, for the really good background introduction. My name is Sara. I am a PhD student at UCL, and I will just explain the workflow that Federico discussed on the alveolar bone augmentation and the technical considerations to be followed. So first of all, the requirements for bone grafts. So as Federico was mentioning, we want a graft which is biocompatible, patient-specific, that will easily match the shape of the patient with suitable mechanical properties and which degrades, but more importantly, promotes bone remodeling and have enough porosity to allow for revascularization and oxygen flow. 3D printing is interesting for that. As you may already know, it's the controlled deposition of material layer by layer to create a designed 3D object. And it's interesting because it can be used to create really patient-specific grafts, configure a 3D environment, and tweak with the complexity of the scaffold with the inner structure and outer structure. It also allows to create accurate and reproducible scaffolds. So the 3D printing process starts from the design of the desired object into a STL file, the slicing of this for the 3D printing to be able to read it, and the 3D printing process itself. The workflow for the bespoke implants starts from the medical image acquisition, which can be done with MRI, CTs, or CBCTs, and the segmentation of those, which means the partitioning of the medical image into regions of interest. After that, the design can be made of the wanted graft, exported to STL file and 3D printed. But in this process, there are errors in every single step of the process, even starting from the CT scan acquisition. This can be influenced by the equipment itself, by the settings. The radiography scientist will decide the patient bone density, the patient positioning, and the presence of previously implanted metallic implants. But what we are going to focus on is what we have control on, which is the design and the 3D printing of the implant. So there are three main steps in this space, which is the segmentation. As I said, it's just the selection of the region of interest within the medical image, and this can have really errors coming from the software intrinsic property we are going to use, the threshold we are going to use, and the experience of the user who actually designs, and this is really important. For the graft design, the smoothing filters which will be applied will have a huge influence. The Boolean operations and any type of conversions between mask and surface, I will explain that just later on. And then for the 3D printing, it depends, of course, on the 3D printer hardware itself, but really a lot on the material and on the post-processing of the material which are required. So as Federico was just explaining, we focus on the alveolar bone graft, which is normally done by harvesting an autograft from the chin and place. And the surgeon has to spend a lot of time in surgery and exposing the patient, increasing its morbidity to just try to augment the ridge. what we tried to do was to optimize this workflow in order to avoid all the previously mentioned errors. And for this, we decided to create 3 correction factors in the process. Our design was, our experimental design basically took into account 10 lower jaws with bilateral defects, so 20 defects in total. 10 were done with an autograft performed by Federico, and 10 were done with a bespoke 3D printed graft, also done by Federico. And the process was optimized. I will just present it now. So the first step was to do the segmentation, so the selection of the regions of interest. After making the template defect, which was 1 centimeter by 1 centimeter on the lower pig jaws, and after taking the CBCT of the pig jaw, we segmented it, and we obtained a 3D visualization of the mask, as you can see here. So this was done by using a thresholding tool in the software image processing software. But the problem is that it really dependent on the user experience and on the amount and levels of thresholding used and intrinsic properties. So to account for this error, what was done is that the measurements of the pig jaw were taken both in the 3D visualization, so in the segmented part, and in the CBCT itself. And the difference was accounted as the correction factor number 1. And that was used to scale up or scale down in the case if the error was positive or negative for the final design. The second step was to design the implant itself. So the clinical requirements for this, as Federico was explaining, were that there needs to be an 8 millimeter thickness across the jaw in order for the screw to be successfully placed afterwards. So we took a cuboid structure as a reference structure shape, and we just place it in front of the graft. We rotated and positioned it correctly, our cuboid structure, and we made sure that we had 8 millimeter across the wall graft. We double checked both on the visualization mask and on the CBCT, as you can see here. Once we were happy, and once Federico was happy with the placing of this cuboid, we then decided to clean up and remove whatever was not necessary for the defect we created, as you can see here, and we removed this mask. After that, After this step, we end up with a graft, and as you can see here, there are many irregularities on the surface, and this will not be accounted in the slicing software. It will not be detected. Therefore, we need something to smooth it and to make the surface really smooth. And for that, we use a recursive Gaussian filter. You can see in this graph that as we apply the recursive Gaussian filter, even though we are just using a strength of 0.1 or even 0.5, the surface area of the graph will significantly decrease. And so will the polygon count, which is basically the information on the surface, which is, for example, this little part. This will really decrease. So what will be important, especially for the surface, we want the graph to really match the bone defect. So we are going to use this, calculate the difference between before and after filtering for every pig jaw graft. And we will use this reduction in volume to scale up our desired file before printing to have really the right dimensions. And then finally, the third step of correction, which is the 3D printing part. And as I was mentioning earlier, it's really dependent on the biomaterial we're going to use. So as Federico was mentioning, there are a lot of choice out there in terms of materials we can use. Metals and polymers allow to have lower morbidity, yes, but do not always allow for smooth recovery and new bone formation. On the other hand, bioceramics allow for both low morbidity, a smooth recovery, and new bone formation. So for this, we decided to use hydroxyapatite as our candidate. It is similar to apatite in bones. It's biocompatible, and it's widely used in the orthopedic and dental application, but often as a powder form. So we decided to optimize our ink first. We saw that by increasing the hydroxyapatite concentration in the binder, which was based on hydroxypropylmethylcellulose, we can see that the printing quality and the printability increases up to a point before it is not printable anymore, and so does the viscosity. Then once we optimize the ink formulation, we then move to the 3D printing basic parameters such as the needle size, the printing pressure, and the printing speed. In this case, we use a 20 gauge needle, which is around 0.41 millimeter diameter, and the pressure was just optimized visually. Didn't have to be too low or didn't have to be too much, just had to be as showed in the middle picture. And finally, we checked the maximum printing speed, which would still allow for a good printing quality because the printing time really should be reduced as much as possible. Another important aspect to take into account is the layer height. So if we decide to use layer height, which is the same as the needle diameter, which technically should create a perfect object, we can see, as you can see in the left picture, that there is a gap between the needle and the object. So when we put the layer height too low, we can see on the really right side, we can see on the right side that the material is too extruded and the printing time is dramatically increased. Therefore, we found that 0.25 millimeter was the optimal layer height for this application. We also, as we are taking into account hydroxyapatite, we know that to increase its mechanical properties, a sintering step can be added. And we tried different combinations of temperature and sintering temperature maintained in terms of hours. And you can see from the FTIR graph that any of those temperature actually allow to have hydroxyapatite in its state. Therefore, we decided to choose the highest sintering temperature. And then the optimization of the infill density is also really important. We saw the difference between 25% and 100% infill density and compared that with the compressive strength of the mandibular trabecular bone found in the literature. And we saw that 75% infill density with a sintering temperature of 1,320 degrees for 5 hours was actually in the range of the majority of the studies and the densities in terms of compressive strength and density. And finally, as we sinter the scaffold, depending on the infill density, we will have a shrinkage of the scaffold itself. So what we did was to try to calculate how much of this person's reduction was happening in each scaffold for each infill density, and we see that there is a linear relationship between the infill density and the sintering temperature. And that allowed us to have some linear equations to then decide to have different infill densities and to then take into account the percentage reduction. So what we did to validate that, we used the case study of radius malunium. As you can see here, we on the top, on the A part, we have a plastic replica, and we inserted hydroxyapatite printed scaffold graft inside, and that graft was actually scaled up depending on the percentage reduction of the sintering temperature used. And we, to validate that this equation and this factor were correct, we then took a CT scan of the 3D printed plastic replica, and we saw that, you can see in the C image, that based on the distance mapping, there is maximum 1 millimeter malunion between non-contact between the plastic replica and the graft itself, which is clinically satisfactory. And we use that equation to then have our correction factor number 3, which is due to sintering, and that was used to scale up our graft before printing. So after all these 3 factors were taken into account, we finally 3D printed our grafts and performed the surgery. As you can see here, all of those were done, optimized, and so we really focus on the surgical part. We took into account the time of surgery, the accuracy of surgery, and also the number of surgeries needed, and the clinical observations and outcomes from the clinical team. The surgery steps were as follow. On the left side, you can see the autograft, where autograft was harvested from the donor site of the jaw, placed and tried to be reshaped and trimmed, and finally placed as required. And on the other side, you can see how just one-step surgery for the hydroxyapatite graft, which was just placing with a screw and that's it. So the results in terms of time, of course, there is some time to be done, to be taken into account before the surgery for the design and 3D printing of our hydroxyapatite implants. The design, once all these factors were already optimized, took in average less than 5 minutes. Also because the user was experienced in that and the process was already optimized. The 3D printing step was 2 minutes, and the sintering time took around 25 hours. But the good thing is that all these pig jaws could be sintered at the same time. So in total, I would say that the overall pre-surgical design and 3D printing and sintering took around 1.5 days. And then moving on to the surgical time, we can see that the autograft took around 5 or 6 minutes, also because, of course, the surgeon had to harvest the secondary graft from the donor site of the pig jaw and reshape it. And the graft implant took in around 2 or 3 minutes, and that was due to the reshaping part. The 3D printed graft took sometimes even less than a minute because only the screw needed to be placed. Of course, these measurements in time are not representative of what could happen in a patient because the patient is much more difficult to access in terms of the jaw and a dead pig jaw is much easier to perform surgery on. But that just shows that how the reduction is actually interesting for the surgeon. So the results of the accuracy, at the moment we are waiting for the CBCTS to be done to confirm the accuracy. And this delay was due a little bit to the COVID situation in the UK, with hospitals being closed. But what we can already observe by eye in these 4 examples of pig jaws is that there are some gaps on the autographs, as you can see in the pig jaw 3. In this hole, normally, I guess the surgical team would insert this powder that Federico showed before, which could be hydroxyapatite powder or any other type of powder to fill the gap. And you can see that on the other side, the 3D printed implant is really matching all this. Similarly for the pig jaw number 5, 8, and 9. But we still need to wait for quantification of this accuracy from the CBCT, which will come soon, hopefully. And yeah, that is the end of the presentation. So thank you very much for the time.
Thank you, Dr. Federico and Dr. Sara, for your insights in 3D printing in periodontal bone regeneration.
Thank you, Dhaval, for the invitation anyway.
Thank you.
With that being said, I want to take some opportunity. I hope you enjoyed the talk, and I hope it was really time.
Hello. Yes. So Dr. Dhaval, thank you so much for hosting a wonderful event, and also to have Dr. Sara Melperi and also Dr. Pero. I think it is actually insightful. I was backstage for some time in terms of also, and then subsequently then have back-to-back trial sessions. These 2 days were really tough in terms of having almost 22 set, sessions back. But it was really engaging, and I'm sure these inputs will be of great help for dentists, professionals, researchers, all of them benefiting from this 3D printing technology. And thank you so much, Dr. Dhaval, and the other respected doctors who have also, lent their time for sharing your expertise in the subject. Thank you so much, and I would request you all to join the other sessions, as per your convenience, and also stay back to the evening, because evening we are also acknowledging some of the initiators in the space globally. The idea is to recognize these respondents who've been doing some great work in 3D printing across specialization, maybe from neuro to orthopedics to cardiology. So at the gamut is slightly bigger in terms of addressing and also acknowledging the efforts made by everybody. So thank you so much, Doctor, and thank you so much, Dr. Dhaval, for your time. Always a pleasure to have to connect with you and get your insights coming through, and so that it is a good platform to share insight and knowledge on the subject. Thank you so much. So can I have everybody on their videos on? So we'll have a click of a photo. Generally, you have it on the stage, but now we have to do it virtually so that everybody on the stage with a smiling face. Yeah. So I will just click on.
Sure. Sure.
Yeah. So 1 second. Yeah. So yeah. Yeah, Doctor. Thank you. And 1 second. Thank you so much. Thank you so much. And it's a pleasure to have you all.
Thank you. Thank you, everyone.
Thank you, Dr. Federico, Dr. Sara, Dr. Shibu. Thank you once again for giving us insights in the cutting edge work your team is doing at Eastman. Thank you so much for your time.
So Dr. Pero, Dr. Dhaval actually spoke really high about you in terms of the good work that you, even Dr. Sara, you both. And so it's a privilege to have you both on the platform. Thank you so much for your time.
Thank you for the invitation, guys.
Bye.
Namaste from India.
Thank you.
Thank you.
Yeah.